Okay. All right. So, welcome everyone. I'm Jerris Hedges. The reason I'm giving this lecture is I practiced emergency medicine for a little over 30 years. So I've had a chance to see a few people with abdominal pain. And this lecture was selected just to give you a bit of a clinical overview, take some of the topics you're discussing now, kind of put them in a clinical context. You're going to hear a lot more about abdominal pain when you do a number of your clinical clerkships. And there will be other opportunities through some of the PBL sessions to talk about abdominal pain as well. So think of this as a big picture sort of discussion. And we're going to hit some of the high points, but a lot of it's going to be more to give you the context without having to get into every detail. Okay, so let's get going. So these are some of the topics we're going to talk about. We're not going to get too deep into the physical exam or into diagnostic studies, but you'll see a little bit of that as we go through a couple of cases just for keeping you interested about what's coming later in your medical school education. So we're going to focus more on why do we have abdominal pain, how does it present, and a little bit about how to recognize when something is bad. And if there's anything you can walk away with in regards to any of the pain conditions that you will see, knowing when something is bad versus benign is probably the most important thing. But you won't get it from one lecture, you won't get it from one patient. It'll be something you acquire accumulatively during your experience. But we're going to touch on some of the things that may be helpful. Okay, so from a physiologic standpoint, I want you to think about how and why we experience pain. Now, some of this you're going to see in the second year when you get into the nervous system. But I want you to think now about, our brain is sort of how we're not only thinking about the world, but how we sense, sometimes subliminally, what's happening with us. And we wouldn't know we were having abdominal pain unless we were getting signals back from the abdomen to the brain. If you took someone and you cut the spinal cord, and unfortunately we have some individuals who've had serious spinal injury who've lost the ability to feel below the diaphragm. Those individuals don't sense abdominal pain the way that you would sense abdominal pain. Sometimes they just get an impending sense of something's very wrong. Sometimes there's distension of the abdomen that they can sense around them, but they don't necessarily have a feeling of pain. And as our pain pathways degenerate, which sometimes happens as we age with neurologic conditions, our ability to sense pain may be disrupted. So it's a sensation in the brain, it's abdominal pain, and it all starts with a nerve receptor. We call them nociceptors, noci standing for it's sensing pain. And it then sends an impulse up an afferent nerve. And afferent probably means nothing to you, but it is the nerve that goes from tissue up towards the brain, towards the spinal column first, and then ascends to the brain. It has a couple of stops along the way. The nerves that lead from our body's tissue, then they go to the spinal cord, they branch, cross over, and go up the anterior spinal thalamic in the anterior lateral spinal cord. So it's a little bit complex, and it doesn't even go to the part of the brain where we sense position sense and other sensory things. It goes first to the thalamus, then it projects up to the cortex. So anywhere along the line you can have a problem. Now we're going to talk a little bit about somatic versus visceral. So somatic, if you've talked about musculoskeletal at all, that refers to your musculoskeletal system. Now, why is that important? Because the same nerves that are bringing sensation from our muscles also are bringing sensation from the lining of the abdomen. The abdomen's lined by the peritoneum. And so that when the peritoneum gets irritated, the sensation travels with the same pathways that your muscles use. The other pathways is the visceral, and all of our solid organs and also the hollow organs in our abdomen that are not immediately touching the peritoneum, their sensation is following both the sympathetic and parasympathetic nervous system. And what's important about that is you don't have as many nerves in the visceral tissues as you do in the musculoskeletal. And we use the musculoskeletal every day because just myself standing here, I've got to feel my muscles, I've got to know where I am in place and space, and I've got to be able to coordinate those muscles. So I'm feeling those, and we're aware of that. Most of the time in our abdomen, we don't have any attention paid to what's happening with our organs. Occasionally, you'll feel a little cramp in an intestinal structure. That can cause a little discomfort. But most of the time, we don't even pay attention to that. Okay, so I told you there are the pain receptors, but what triggers those pain receptors? They can be triggered by stretching or pressure. And we can see that if the bowel becomes obstructed, it gets distended, or the bowel's working very vigorously, you'll feel those mechanical receptors. The other is chemical mediators or inflammation, and you'll be studying throughout your first 2 years a lot about inflammatory products. There are cytokines, interleukins. These are all with various purposes in the inflammatory process, but they can trigger what's happening in the nociceptors. And then our positive ions that we have in the body, we have a lot of potassium inside every one of our cells, and if our cells break down and release potassium, that'll be sensed by these painful receptors. And we have a lot of positive ions that we use in the stomach. We secrete hydrogen ions so that we can help break down our food products. If that goes deep in the tissue or that gets released because of a perforation in the bowel into the abdominal cavity, then you're going to get pain and inflammation. Now, something you may not think about immediately is when your metabolism goes from aerobic to anaerobic, from ischemia, you also, with lactic acid, you also release hydrogen ions as well. So ischemia can trigger these nociceptors. So the big pathways or triggers are trauma or obstruction, and there's all sorts of trauma. It can be penetrating, blunt trauma. And then you've got ischemia, which can be from poor blood supply, or you can have toxins that someone can ingest that can cause irritation to the lining of the bowel. And then we have infections and immune reactions. Now, the immune reactions, part of the inflammatory process, is just that our body fails to recognize our own tissue and minimizes the amount of the cytokines and interleukins that are released, and it starts attacking its own tissue, and we draw white blood cells in there, and you get an advanced inflammatory response, even without an infection. So there's certain bowel conditions. Some of you may have heard of people with Crohn's disease. That's one of the conditions that can be a self-perpetuating condition. And even people who have a problem with pancreatitis, where the pancreas gland gets inflamed, many times that's a self-directed immune process. Okay, so what are our challenges? One is just to recognize that something's going on that's triggering the pain. And if you're a very young person or a very old person or a person who's had head injury, or I mentioned the spinal cord injury, can be significant problems recognizing the presence of pain. Also, localizing the pain is difficult because for visceral pain, there's very few receptors, and the location of the pain is felt very generally. And I'll come back with a little diagram to help explain that in just a second. Communication of pain is another big one. Again, if you're very young or very old, you may not be able to explain where you're feeling the pain or what the nature of that is, and it becomes harder to interpret what the underlying cause may be. Also, if you have a different language or a different cultural background, it's very difficult sometimes for people to understand how you're trying to explain the pain. So, can be very articulate, but maybe not with the person who's trying to get that information. So that's really important that we acknowledge our own limitations sometimes in terms of getting the information from the patient. And then there's a time-associated factor. So what do I mean by that? What I mean by that is not all pain begins at point X and goes away at point Y. There's a wide variation in terms of the way pain comes on, the way it may get better, or the way it may worsen. And people will interpret it different because the underlying processes may vary a little bit. And even some of the most harmful conditions creating pain may look very much like a minor condition when you first see them. And you'll have to observe and evaluate the patient for a bit of time to see whether it's getting better, staying stable, or is actually an evolving process that should make you very concerned. Okay. Now, everyone in medicine loves mnemonics. This is one of many that you will see. This alphabet approach has a lot of helpful information. But let me give you the big picture is that you cannot make a precise diagnosis of abdominal pain, even if you get a good answer for each one of these, because there's a lot of crossover in the conditions and how each patient interprets the pain they're experiencing. Okay, so L stands for location. There are some associations with certain diseases in different anatomic locations, and we'll talk about that in a bit. I'll show you a graphic on that. Sometimes the pain can be related to meals, and it's triggered by what someone's eating, and so knowing what they're eating and any supplements or medications they're taking may be helpful. But again, with rare exceptions, you don't necessarily get the answer from that information alone. Helpful to know if the patient has had this patient before or this is the first time. Again, that's a subjective thing. They may associate something they experienced in the past with what they're experiencing now, but it could be a completely different condition. We do see people who have like a recurrent inflammatory condition. They will often describe, I'm having what I had before, that I know this is a flare of my disease, I'm going to need to be treated with X, Y, or Z. They often know their disease very well, and they just don't have necessarily access to the treatment at their home. So that can be helpful, but probably isn't the most common thing. The onset can tell you a bit. Pain that wakes someone up at night, usually a more significant problem, but not always. They could have eaten something 4 or 5 hours before they went to bed. It could have had some bacterial toxin in it. Then they wake up very uncomfortable. On the other hand, if they had an ischemic event to their bowel while they're sleeping and they wake up with severe pain, that's a big problem. But it may not be discernible simply by when the pain began. Palliative and provocative, two sides, yin and yang. Palliative, what makes it better. Provocative, what makes it worse. These sometimes help us, but you can take someone who takes an antacid and they say, my pain gets a lot better. And you say, well, could be because you had too much stomach acid, you've got maybe some irritation of your stomach lining, an early ulcer, or maybe the lower esophageal sphincter is irritated, and you've got some gastric reflux. But it could be that that was all coincidental. So I think you're getting the theme here. I'm giving you sort of what we're looking for with the information, but I'm also trying to warn you that there's always a danger in overinterpreting what you're hearing. So, quality. Boy, this is really the big one where people get misled. Because you'll often have your colleagues say, if they say this, you got to think about this. Well, it's good to think about it, but it doesn't diagnose it simply because someone uses a descriptor. Because we all choose our words based upon how we learn language and how language is used around us, and it's not necessarily the same. So when I practiced in the Midwest and someone said, I've got a sharp pain, I quickly realized it doesn't mean they feel like someone's stabbing them with a knife, but rather it's a severe pain to them. So it really had nothing to do with the quality per se, but more the severity in their use of the language. But you'll hear people talk about burning pain, gassy pain, crampy pain. And we think we know what that means because of how we use the language, but it isn't always the same with the person we're speaking with. So be careful here. That's my main point. Radiation referral. I'm going to talk about a couple of examples because this can be a really helpful thing when you see it, not always a common part of the workup. But what we're talking about here is a couple of different phenomena. And the suggestion is the pain isn't just in one place, but it's sort of referred or maybe it moves to another area. So that can happen a couple of ways. Let's take the example of a 12-year-old riding a BMX bike. They go over a bump on a course they've set up. They fall forward. They hit really hard with their the steering on their bike handlebars against their upper abdomen. Now, they may fall from the bike and tell their parents when they come home that, I thought I was okay, but man, my shoulder's killing me. Or my shoulder really hurts. And so you bring them in, you work them up, and they're also a little tender in their stomach. And you get an x-ray of the shoulder, it looks good. So what you should be thinking about in that case is the pain in the shoulder because the brain is misled? Because the same, the nerve nociceptors in the area of the hemidiaphragm, where a ruptured spleen will leak blood and cause irritation of the hemidiaphragm, they enter the spinal column in the same place as the nerves from the upper thoracic area that you feel in your musculature of the shoulder. So that's one example of a common, what we call referred pain, which in reality is sort of it's a trick. You got to be aware that your body is used to interpreting pain more in the musculoskeletal system than in the abdomen. Okay, what's another one? Somebody's trying to pass a kidney stone and they've got severe pain and they feel it in their back. It's where pain from acute inflammation or distension of the kidney would be. But then they feel it down in their groin. How could that be if it's a kidney problem? Well, if they're passing a stone and it's causing irritation by distending the kidney first and then passing down and causing spasm of the ureter, which drains into the bladder, Then they have this movement of the pain, which they started in the back. Maybe it's still there, but it's much worse down in the groin area. So that's a referral mechanism. Another example, and this uses the radiation from the standpoint of a change from a visceral to a somatic pain. So you're all familiar with the concept of appendicitis, but maybe don't know yet the steps in the process. So the cecum has a small worm-like tubular structure that has a blind end, so it's kind of a pocket that sits on the end of the cecum. That's our appendix. It's a vestigial organ that in other animals is used for digestion. Well, it's got a small enough opening into the cecum that it's easy to get a hard piece of stool or a pit that you might have swallowed to impact and block that opening. Now, blocking the opening isn't necessarily painful, but because the appendix still has lots of bacteria in it, the bacteria multiply and they begin to distend the appendix. So it's like blowing up a balloon, and it can't be released because you've got this blockage at the opening. And as it distends, your brain starts getting signals from the viscera, the hollow viscera of the appendix, because of the stretch. And where do you feel those? I'm going to show you a diagram to explain this a little bit, but you feel it in the periumbilical area, around your belly button. And you can't locate it very well. It just doesn't feel right. And because it follows the parasympathetics, it may even trigger a little bit of nausea and occasionally vomiting there. Now, if that was all that we had experienced, it wouldn't be so bad if it eventually got relieved. But what the body experiences then is, with that continued distension, the blood supply to the wall of that swollen appendix is compromised and therefore you get ischemia and inflammation. That will cause irritation because your peritoneum that lies in the area of where the appendix is, it's getting these inflammatory cells and the cytokines and leukocytes, interleukins, all irritating the pain receptors in that peritoneum. So now the person begins to notice, hey, it hurts down here, my right lower quadrant. And if you were to push on the abdomen, they'd tighten their muscles up to protect it so you wouldn't be able to push as deeply. Their bowel sounds may get a little bit quiet because that inflammation is telling the bowels to slow down. If you start moving too much, it's going to cause irritation there. And they may get what we call a rebound tenderness, where as you push down and it hurts, you release it suddenly, and their abdomen tightens up and they complain of severe pain because they have reflex irritation from that peritoneum being first stretched and then kind of released. Okay, so think about what the brain is experiencing. It's saying something happened, I feel bad in my umbilicus, but now 2-3 hours later, it's down here in my groin. It's like it's moved down there. So people talk about that radiation. It's the same process. It's just at different stages in the evolution. Now, if you can relieve that obstruction to the appendix and block the ongoing multiplication of bacteria in that blind, distended appendix, you can get a spontaneous release of the appendicitis. In fact, that's an increasing area of interest because there are a lot of people who've been found to have recurrent appendicitis because they have spontaneous resolution of that obstruction, and then you knock down the infection, they get better. But once you have a couple of these episodes, it's almost certain that you're going to need your appendix out. And if you've got a large obstruction in the appendix causing this, it's not likely to resolve spontaneously. But that's a whole nother area. You'll get lots of discussion when you do your surgery or emergency medicine rotation on that. But things that we used to think were very simple, like the appendix, can be a little bit more complex. So that's radiation referral. Severity is important because everyone evaluates something and determines its severity using their own scale. But we try to tell the patient, if you have a 1 to 10 scale, where 10 is the worst pain you felt in your life, and a 1 is just barely there, where is it on the scale? Most people with a nonspecific, self-resolving abdominal discomfort, which is the most common diagnosis of a person in a clinic or the emergency department, they'll have something that has pain around a 4 or so, 3 or a 4, but they're uncomfortable enough to want to come to the hospital. If you've got someone with a 7 to 10, then that's pretty worrisome. And it's likely that they're going to need some sort of intervention. But what's important is, where are they on the spectrum over time? Is it something that has essentially started out bad but is now virtually gone away? That could have been a self-relieving problem. Occasionally we have people who have what we call a sliding hernia, where they have a loop of bowel that gets locked in an opening, causes a temporary bowel obstruction, but then with the movement of their body or the bowel, it is self-released. And then their bowel begins to function again, the inflammation dies down, the pain goes away. So there are some more severe things that start out severe and then get better. But a lot of times, if something starts out very, very bad, you should be very worried. Now, this is for virtually every painful condition. So if someone tells you they have a headache, that's the worst thing they ever felt in their life, and it came on within 20, 30 seconds, be very concerned about them having an aneurysm that's bleeding in their head. If you've got someone who has severe pain in the chest that came on very suddenly, better worry about a thoracic dissection, tear of the aorta, or a heart attack. If they have the worst abdominal pain they've ever experienced, and that came on suddenly, you worry about a major obstruction or a vascular ischemia, where they have a blockage of their mesenteric artery and now they have dying bowel. Okay, now you don't have to think you're going to have to memorize all these things. I'm just trying to put it into context, because you're going to see these terms a lot in the future. Temporal features, we're sort of getting to those about things getting better, things getting worse. That can be sometimes helpful. The best thing is to have someone with mild pain that started and now it's slowly going away, and they've got symptoms consistent with some sort of a bowel irritation from something they may have eaten, especially if you've got other family members who have it. Now, some interesting things, since there's other things in the differential that can be a problem. One of the things that I always get concerned about is when a family comes in and they've all got some sort of complaints, headaches, weakness, dizziness, and maybe the child has abdominal pain. That could be a toxin they ate, but it could also be a toxin that they inhale. Carbon monoxide can cause this sort of constellation of symptoms, and the younger person will have a greater symptomatology. And it's interesting because it isn't always in the wintertime when you'd expect that. Sometimes it's people that have used, they have gas-powered, water heater or so, and the venting is bad, and then everyone in the house develops some symptomatology. Okay, so let's talk. This is a case. Essentially what we were talking about with appendicitis. This is sort of a classic presentation. Young woman comes in, has had 12 hours of pain, started in the umbilicus, went to the right lower quadrant, now tender with deep pressure, has a slight fever. So the presence of fever suggests either infection or severe immune process. Nausea, again, that can be due to the autonomic symptoms and distension of that appendix, but no diarrhea. Now, I've seen appendicitis with all different constellations, and you can get a little bit of diarrhea with appendicitis. But when you don't have it, and someone gives you this story, it really points towards appendicitis. Now, even with this perfect story, this could be due to something else, and sometimes something benign. We have cysts that sometimes develop on our mesentery, and those cysts can become inflamed. And so you can have someone present with this sort of story from an inflamed cyst that's going to be self-resolving. Now, this is someone where if you get a CT scan, they're probably going to be looking fine if it's a benign condition like a mesenteric cyst. I also had an interesting person who was eating a hoagie, which is like a Subway sandwich, but in Philadelphia they call it different things. And so the hoagie, they had these toothpicks with a little plastic feather on the one end, and someone was eating it a little too vigorously. They swallowed the toothpick. Went down the esophagus, fortunately, went into the stomach, and they thought they were going to be fine. But about 3-4 days later, they started having this very same sort of presentation, and they had a perforated cecum with a localized abscess instead of appendicitis. But we took the patient to the operating room thinking we were going to be taking out the appendix. They got that taken out anyway, because when you're there, you got to take it out. But it was the toothpick that was the problem. Okay. So imaging, you're going to learn a lot more about imaging. And the key thing is, think of the patient standing in front of you. So their right is your left, their left is your right. Now, when we're doing abdominal x-rays, CTs, we're lying the patient down on their back. So that's the first thing is you want to think about orientation. This is someone lying on their back, and hence, because they've sort of been leaned back, their right side to be here. Someone cleverly put an R for the right, and they cleverly put an L for the left. They don't. You may see images and they don't have those markings, but just remember what the anatomy should be. Okay, so after you know that this is the dorsum and the right, because they're on their back. The ventral is anterior or superior in this case. Then you got to decide, well, the CAT scan takes a bunch of cuts, depending on where you set it, and it just sort of goes down the body. You decide which parts are going to get imaged, and then it reconstructs it. But you're looking at these cuts and you got to say, what level is this at? So this is, I'll tell you, is in the mid to lower abdomen. Now, why can I say that? Because it's not in the upper abdomen because we don't have any ribs. We don't have any liver there. Don't even see the kidneys. So this is someone who has a condition that is in their mid to lower abdomen. It's not the lowest part of the abdomen because the lowest part of the abdomen goes down into the pelvis, and there's no pelvic bones there. So that's the level we're at. We can also comment that, this is a lumbar spine, because if you're familiar with a lumbar versus a thoracic vertebra, and they look different. So this is a lumbar spine. And you've got the aorta and the vena cava. We always look for those. If someone's been losing blood and we're worried about they have some sort of hemorrhage in their abdomen, they might have a flattened vena cava, and you may see fluid layered within the abdomen. Now, someone put a little box there. It's really not common for you to get a CT scan back with a box there, but they did it to draw our attention to there. So in the middle of that box is an ovoid structure, and that structure, right now I'll tell you it's the appendix, but we don't know for certain by looking at this. It could be a loop of bowel that somehow got distended. But there are a couple of interesting things. Number one, we can sort of make out an interior and exterior wall, and the only way you can do that with a small bowel is when it's distended and it's engorged with blood, and that blood makes it very dense and allows the inner and outer walls to show up. The other thing is if you look at the very tip of that, and same thing here, there's something that's a little denser. It's not real big, but it's a denser. So that's a calcified bit of stool probably, or something calcified that was in the diet that was swallowed and then obstructed the lumen to the appendix. Now, why do we say that with confidence? Well, again, the patient's on their back, and if this were just floating free in the bowel, it would fall down, but it's stuck up in the ventral position. So this is an impacted appendicolith that's distended the appendix. Now, the other key thing that should have caught your attention, and it will in future, is that there's a haziness around this distended appendix. That haziness is due to the surrounding inflammation causing these capillaries and small vessels that are going into the fat tissue around the appendix, causing them to leak. And so you're getting the leakage of fluid into the adipose tissue. Otherwise, the adipose tissue wouldn't be very visible at all. Okay, so this would be someone that we would get our surgical consultant for. High probability that they're going to need to go to the OR. You're not likely to get this to resolve spontaneously. If it is allowed the process to continue, what happens is eventually the body will decompress that appendix. Unfortunately, if it decompresses the bacteria and inflammation into the abdominal cavity, you get an abscess. If that abscess is not well controlled by the body, you then get a generalized bacterial infection in the peritoneum. It gets into the bloodstream. They get a condition we call sepsis, so they get a high fever, tachycardia, low blood pressure, and they're very toxic from that. And so we know that some people have died from a ruptured appendix, and that's the process that takes place. Now, as I said, if you don't have an appendicolith, it's not super distended, you're catching it early, sometimes you can make them comfortable with IV medication, give them fluids and antibiotics that cover the enteric bowel organisms, and about 40 to 50% of them will resolve with medical treatment. The problem is there's a fairly high probability of recurrence. So it's always best to work with a surgeon and have them work with the patient to decide which way they want to go with this. But the nice thing is where we used to feel like we had to call the surgeon in at 2 in the morning to go take the patient to the OR, we know we can manage the patient medically for at least a few hours and let them sleep a little bit and come in and do this as their first case. Well rested. If I had my appendix removed, I would want my surgeon well rested. I wouldn't want them disturbed in the middle of their REM sleep in the middle of the night, if at all possible. Okay, I said I'd show you a little graphic to bring home the point about autonomic versus somatic. Somatic, we tend to think of pain in quadrants because generally our organs are laid out sort of in quadrants, and where the inflammation is in the adjacent area, that's where you're going to feel the pain for somatic pain. And it usually comes after the less well-localized visceral pain. So in the visceral pain, if you have some lower thoracic structures that may give epigastric pain, and you may recall from some of your cardiovascular things that someone having a heart attack may complain of indigestion or epigastric pain. It's one of our big challenges, is trying to sort out what's cardiac, what's lower esophageal or gastric. But in addition to the lower thoracic problems, the lower esophageal sphincter, the stomach, the duodenum, the pancreas, the liver, spleen, all of those can create epigastric discomfort. And until there's adjacent peritoneal irritation, it's just vague, sometimes very severely discomforting to the patient, but very vague in the epigastric area. Then if you go from the distal duodenum, the ileum, down to the ileocecal valve and the appendix, you're in the periumbilical area. So although the appendix is something we kind of associate with that periumbilical pain, anything proximal to that, in jejunum and the ileum, that can also cause periumbilical pain and be very difficult to sort out from an early appendix. And then your ascending, transverse, descending colon, and all your pelvic structures often are felt early on in the suprapubic area. Again, we've got a lot of structures in there, and that's one of the reasons it's tough to sort out abdominal pain, especially in an early setting. And that's why we ask all those questions, but keep in mind that no one of those questions I outlined is going to give you the definitive answer. Now, I think everyone has a slide set, and if you're going to go back and look at the slide set, one of the most important things to look at, and you can't read it in the room here, but you can if you project it on your computer, is this sort of general pattern. These are some conditions that cause sort of a diffuse discomfort. These are conditions with right upper quadrant, right lower, left lower, and left upper. I'm not going to read them off now. You can look at them at your leisure. What I'd ask you to do is try to think about, okay, if something's going wrong there, how could that be, and how might that present with someone? And maybe what age might experience that. You're going to be seeing this information again and again through your clinical clerkship. So don't expect to have to associate this with a particular disease now. I more want you to be thinking about the pathways and process that happens. Now, the other reason I like showing this is the guy who made this slide was one of my mentors when I was in training, and it actually was published in 1978, so I'm dating myself. Okay, so let's take a couple other quick things, and I know we're kind of running out of time a little bit. So the pancreas sits here, and what you're seeing is a fuzzy pancreas. You don't see any sharp borders. It's all fuzzy because it's inflamed. And it could be inflamed for a number of things. We know one of the most common causes for the pancreas to get irritated is from chronic alcohol use, but not everybody who uses alcohol chronically gets pancreatitis. Some are just more susceptible. Alcohol can be a toxin. It can trigger the release of the pancreatic enzymes in the pancreas itself, causing autodigestion. What are other causes? One is a semi-mechanical, and that is as we pass bile, it goes down the common bile duct to get into the small bowel, but it also is met by the pancreatic duct. And so pancreatic enzymes are released to go down with the bile to help with digestion. But if you block from a gallstone the pancreatic duct, it'll cause back pressure and breakdown of the pancreatic cells, causing more autodigestion. Now, toxins can do this as well, and people with hyperlipidemias can have autodigestion problems. And every board has this, but it's so rare. But scorpion stings, they can trigger a pancreatitis from the toxin. Do we have scorpions in Hawaii? Yes, we do. And they like dry climates, so you're not going to see them much on the windward side, but out on the other side, yeah, you may see some if you're looking hard enough. Okay. All right, just a couple things. This is upper thoracic because we see ribs and there's liver here. There's a somewhat distended gallbladder. There's no visible stones on that single shot. You got your aorta, you got your distended venous, so it's well hydrated. You got two kidneys here. The kidneys look slightly different size, primarily because they're sitting a little bit different. On the right side, the kidney is depressed a little bit, so we're looking actually at the top of the kidney. Here we're sort of midway in the kidney on the left side. Okay. All right. This is one of your nightmares. You're working in the emergency department and a nursing home sends in an elderly person who has a distended abdomen. They have been eating well. They're a little bit tender, and it's been going on for 3 days, and now they can't really communicate much. They never communicated much before. Anyway, so what's going on? There could be a lot of things going on, and this person, because they're elderly, they're not communicating, it's not going to be easy to just ask questions. You're going to likely have to do a lot of laboratory tests, urine, CBC, liver enzymes, lipase for your pancreas, urine analysis, and imaging, because otherwise you're not going to get any answers. So what are some major things we think about? Bowel obstruction is probably number one at that age and with that presentation. Bowel obstruction, as I'm going to show you in a second, can be due to a ton of things at that age. I don't know what being a member of the American Automobile Association means, but some people would be worried about an abdominal aortic aneurysm, which can cause not a big stomach, but it can cause leakage of blood with a secondary ileus, which is a dysfunctional bowel that doesn't want to contract because it hurts too much. And then you've got the buildup of bacteria that cause more gas, and so their gas is distending the abdomen. That's what's causing it. The kidney stones can also cause a secondary ileus and distension. What I like to call obstipation, essentially functional obstruction of the bowel from constipation. If this patient's getting opioids, if they're getting anticholinergics, if they're getting iron tablets, if they're getting calcium tablets, all of these can lead to a decreased motility of the bowel or concretions and a functional obstruction. But sometimes just dehydration and not getting up and using the toilet can be the same problem. I didn't mean to go there yet. If you have an obstruction long enough, you can have a perforation, a localized abscess. Males of this age tend to have large prostates. The prostates can cause progressive distension of the bladder, and sometimes that'll look like an acute distended abdomen. I've seen people with over 2 liters of urine in a distended bladder. That's sort of gradually filled up over a several-week period. So that, fortunately, can be decompressed, and the patient may not need an immediate abdominal surgery, but they may require a urologic procedure. Okay, so those are things you'd be thinking of, not the only things, but things. And then there's all the things that cause the bowel obstruction. Adhesions are scar tissue within the abdomen, often from prior surgeries. You can lock bowel up, get it obstructed. Hernias can form. They can have an abdominal wall hernia with a weak spot. They can have an inguinal, direct and indirect. They can have an obturator hernia. They can have a femoral canal hernia. Those are all things you should be learning in anatomy class, but they can cause a bowel obstruction. You have to look for those. The problem, intussusception is an interesting one. We think about that with children. Children get sometimes respiratory infections, and they also involve the bowel. They get swollen lymph tissue, and that lymph tissue, their bowel treats it like a bit of stool. They try to pass it, and then the bowel telescopes on itself and causes an obstruction. That usually happens in 2 to 4 years of age, and it can be a very major presentation for a young child. But in an elderly person, they can have lymph enlargement. They can also have polyps from a benign or tumorous growth that can then be carried along and pull the bowel in and telescope it just like a child. So in the person who's late 70s, 80s, intussusception becomes more common. This wouldn't be a presentation of ulcerative colitis in the sense of an acute bout of ulcerative colitis. That's a much younger age group, but you can have burnt out, scarred bowel from prior ulcerative colitis. So that could be a concern there. And of course, cancer, the big C, is always there. Okay, we have to decompress any obstruction. If this is a bowel obstruction, then we have to get them ready for surgery. Okay, this is a board question, which you won't see this year, but you might see subsequently. Usually, we like to use a CAT scan because it gives us so much more information, but sometimes you're practicing where you don't have that available. You think the person has an obstruction of their bowel. You want to know about that so you can make an appropriate referral. And if you were to just get a supine film, you wouldn't see the blockage because your X-ray beam has to be tangential to the air-fluid interface. And so when you lean the patient up, if they're healthy, you can stand them up, but it's usually someone with a bowel obstruction or a bit dehydrated, too much pain, and you're likely to have that person tip over and fall on the floor. So we just set the gurney up 35, 40 degrees and get an X-ray that's tangential to the air fluid levels that are there. So that's kind of classic for a bowel obstruction. Maybe perfectly normal supine, but definitely abnormal there. Now quickly, just a couple of things for interest. I was told you the story before about a ureteral stone and pain referral. So these kidneys look a little different, partly, again, because of the level that they're sitting. So if you want to look for distension from an obstruction, you want to look at the pelvis. This pelvis is huge compared to this one. This is not so distended. In fact, there's some discontinuity between the collecting system here and the ureter. Here, it's all distended. If this person gave you the story that the pain moved, then you definitely want to make sure you looked at the lower part of the scan, and you come down, here's the two hips, you're down in the pelvis, here's the bladder, and there on this side, on the right, the same side as the dilated pelvis, you've got a little radiopaque object that's right as the ureter enters the bladder. So this is a ureteral vesicular stone, and that's usually very uncomfortable. We treat them with analgesia, and we also use some NSAIDs because that blocks some of the cyclooxygenase that's causing smooth muscle spasm there. And quite often they'll pass, especially if they're this far along. But occasionally you have to go up the urethra and use a basket to pull that out and remove it. Okay, one more thing, just as some of you are going to see diverticulitis. You won't see it unless you're dealing with someone in their late 60s and older. And it comes on at different ages for different people. But the main thing is that the bowel is very indistinct. There's a very ratty border there. There's little pockets, which are these ticks, the blind pockets, and it acts a little bit like appendicitis in that you can get bacteria that tend to overgrow where these toxins cause local inflammation. And if it persists long enough, the person can actually get transmural migration of bacteria and occasionally even a rupture of the bowel and a secondary either abscess or peritonitis, and it can be fatal to the elder patient. But quite often, if you catch it early and you know what you're dealing with, you can treat it with antibiotics to kill the bacteria that are causing the problem. If it's persistent, then a segmental resection of that part of the colon with the reanastomosis would be needed. Okay. This is just, I'm out of time, I'm sorry, but to let you know that the process is the same as with the appendix when you talk about the gallbladder. Initially, when the gallbladder is obstructed, the first pain you feel is visceral from the distension of the gallbladder, and there may be some nausea and vomiting with that. Very seldom is there any fever. Very seldom is there any problems with abnormal labs because it's all a mechanical process at that point. But then as the gallbladder remains distended, secondary inflammation from ischemia of the wall of the gallbladder takes place. They begin to get some fever and get some tachycardia as well. They get now peritoneal pain, so instead of epigastric generalized pain, now it's very localized to your pressure in the area of the gallbladder under the rib cage. And if you were to look with the x-ray, this one is sort of a longitudinal view of the gallbladder, some stones. There's what we call acoustic echoes here, where you're bouncing sound waves down. They don't all get back because of the stones in the gallbladder. And if you looked at a slightly different angle, you would see stones and thick sludge here, a little bit less thick sludge there, usual gallbladder fluid, and then you'd have a thickened wall, and then there's a rim, a lucent rim, kind of the black there, that is inflammation surrounding the gallbladder. So that's just the process of going from a visceral to a somatic and a highly inflamed. And the further you get along on that trajectory, the more likely they're going to need surgery, and you're not going to be able to reverse the process. So I've sort of run out of time. Just want to remind people that although I've given you some diagnostic clues and tools, majority of people you see, you're not going to be able to say exactly what they have. You're going to learn through your experience. This is a really bad condition. I need a consult, or I need to admit, or I need to operate. And this is a not so bad condition. We're going to watch them and maybe even send them home with observation. So non-specific abdominal pain is probably the most common diagnosis we use, and that's okay. But you got to make sure that things fully resolve. And if they don't, then you have to evaluate these patients further. Be wary of the very young and the very old, and those with other immune complex and other processes, because they're more prone to have a serious underlying phenomenon. Okay, that's it. I went over a little bit, but enjoy this topic a lot. Thank you.